Hello, everybody. I'm Gabriella Stern. I'm Director of Communications at the World Health Organization, and I want to welcome you in the room and on Zoom to this session on global health communications, innovations in global health communications, and also what we can do together to ensure that accurate evidence-based information gets to people and not misinformation and disinformation. So we have 90 minutes together, and I'm just going to take you through a run of show before we get started. My goal today, and I hope it's yours too, is to have an interactive, respectful, constructive conversation about what I think is one of the most, if not the most important information in issue in global health, which is communications. As my mentor and friend Yodi Alakija said on Twitter just the other day, she said, those who influence messaging influence the world. And knowing this, we have to approach our work with humility and in partnership with those who we are communicating to and with, and importantly, learning from. Communications in global health can't be us to you, me to you, I'm telling you what to do. It has to be me learning from you. And throughout the COVID pandemic, I can assure you that I and my colleagues have learned as much from our followers, audiences, mentors out in the world, as much, if not more than they have hopefully learned from us. So the run of show will be as follows. I'm standing in for Professor Saad Omer from Yale. He was going to moderate the session, but he had a family emergency and had to stay back. So I'm going to be moderating. He would have engaged in a keynote conversation with Mike Ryan, I'm looking at him, who's the executive director of the WHO Emergencies Program. In that role, he not only led the global response to the COVID pandemic for WHO, but he also communicated massively through hundreds of press conferences and social media lives and media interviews. And as a person, he's a consumer of communications, whether media, social media, et cetera. So I thought that just to set the scene, we would have a brief conversation, Mike and I, up here. And I'm going to pretend I'm a journalist, which I was a long time ago, and just ask him a few questions. Then Mike will stay up here and we'll bring the panel. We have a great panel and a very diverse panel in that we have two people from the tech industry. We have Hema Buddharaju from Google. She's the health lead. We have KX Jin from Meta, and he's the health lead at Meta. So we have two from tech. We have two journalists. We have Kai Kupferschmidt from Science Magazine, and we have Sophia Smith-Gaylor from Vice. And we have Rupa Dutt, MD, so she's a doctor, but she's also the founder of Women in Global Health. So she's a voice, an activist, and a public health expert and a medical doctor. And then, of course, Mike. So we're going to have the panel discussion for about half an hour among ourselves, and I've encouraged them to make it really organic. I don't want this to be one of those panel discussions where we kind of go down the line and back. And then we're going to open it up to you to ask questions or make comments, you in the room and on Zoom, and then we'll wrap up. So I hope you enjoy this. I hope you get something out of it. I really want this to be meaningful. And without further ado, I think I've done the housekeeping. I'm going to ask Mike to come up. Mike, come on up. And Mike, you're sitting here.
So you're going to pretend to be a journalist and I'll pretend to be a doctor.
Yeah, there you go. Thanks, Mike. Oops, I'm sitting on my papers. Before we get going, I just want to acknowledge something that has happened overnight that's really disturbing and upsetting. Someone has let us know that they were sexually assaulted by a WHO staff at the World Health Summit. And this is public knowledge as they have tweeted about this. We are reaching out to them to offer any and all support and to express how appalled we are and will not tolerate this. We have rigorous investigative mechanisms and ways that they can report this anonymously and immediately. And you can see this on social media because we're trying in different ways to make sure they're safe and that this is reported and followed up on. So I wanted to acknowledge that because it's the most important thing happening today. And Mike, I just wondered if you wanted to reflect on this. WHO is working as hard as we can to stamp out sexual harassment, abuse, assault, and bullying at our organization, throughout our organizations, and across to our partners, because we are fundamentally a network. So anyway, I just thought we would start with that.
Yeah. Can you hear me? Not really? Oh, there. Okay, it's one of those mics. Yeah, it's a very upsetting and disturbing note to start this day and start this session. It's also doubly disturbing. I spent the last week in Uganda and the week before in Pakistan, and I was really pleased to see the way in which our organization and our partners are really stepping up our action and the prevention of and response to sexual exploitation, abuse and harassment, and seeing the seeds and the green shoots of real action on the ground and wonderful teams, mainly women who are sort of leading in the front line. And again, seeing the changing shape of our teams in the front line to see a lot more senior emergency leaders. And it's just really, it's heartbreaking, actually. It's disillusioning to come to a conference like this and then hear this morning. I have to say it's very hard to process, Gabby. I'm stunned because you told me at breakfast and we were supposed to be preparing for this session, myself and Gabby, and it was just it's very hard to even process now this, but this is the world we're in, and thank you for coming out straight away and communicating to the world on it. That's the only way we beat this is being open and transparent. So let's see what comes in the next few hours. But again, our organizations like ours, big organizations, have huge power. We have huge influence. We have the capacity to do great good, and like all big organizations, we have the capacity to do great harm. And the principle of Hippocrates is to first do no harm. And we need to continue working on that. It's just disgraceful.
Yeah. Amen. So thanks. Okay, I'm now going to switch to our topic of the moment. And I'm going to ask you, and I've never asked you this, but
she's asked me a lot of questions.
I've asked you a lot of questions, but Mike, you've been the public face along with Dr. Tedros and Dr. Maria Van Kerkhove, the COVID technical lead. You've been the one of the three main faces and voices of WHO since January 1, 2020, doing hundreds and hundreds of press conferences, social media lives, speeches, panels, mostly Zoom during COVID, obviously. What has it been like trying to get across life-saving information, but also evolving science amid a very difficult climate, geopolitics, anti-vax, anti-science, and also just billions of people around the world who needed help, and we needed their help. Over to you.
Yeah, it's a very strange feeling. I mean, a minor celebrity in one's old age, but it's been a profound responsibility. I've said jokingly inside WHO that every time I open my mouth, it's a career-ending opportunity, and it's felt like that many, many times. My grandfather was in the first batch of policemen that were qualified in Ireland after independence. He fought in the War of Independence and then became a policeman. And he was a wonderful old man. And he taught me one thing, and I suppose policemen would have that thought. He said, always answer the question you're asked. And I've kept that in my mind the whole way through, is to try and answer the question you're asked. Not to go around it, not to authentically communicate your truth and to try and be authentic. And I get it wrong all the time. And but that, in as much as we have a very important role in WHO in doing science and implementing public health, we also have a profound and solemn duty to communicate science and to communicate about health. And it's not something we do naturally very often as medics or doctors. And we're learning from the likes of you, Nika and her team. Alex should be here somewhere, who's been my guardian angel in social media events for the last 2 years. So you were saying that in your introduction, it's about actually understanding that you're in a learning process the whole time. You're never the finished article. Every time you do an interview, every time you engage, you learn something, you go, wow, I didn't know that. And if you see it as that, it becomes a positive experience, even though there's negative moments in it. And yes, there was a lot of attacks and all of that, but it's been an enriching experience, empowering experience for me. And learning how to communicate without trying to simplify, but translate, not to talk down to people, not to say, I'm the expert, now I have to simplify everything that I know in order for you to be able to understand what I'm saying, which is condescending, paternalistic, but actually trying to truly translate concepts for people. And doing that in real time in press conferences has been the challenge of my life, but it's been a huge learning experience. You said it in your introduction.
And just to add on, I mean, what do you think the most challenging, difficult, almost upsetting moments were as a communicator? And then what were the most positive ones where you felt you were getting across, we were getting across?
I think the worst day was when Fox News had a picture of me and they had cages on the sidebar with "this man is coming to take away your children" when we were talking about lockdowns and all of that. I was getting calls from my family in the States saying, please don't come to America. The personalization, I think that's what's been very different. If you communicate as an organization, and the organization should be criticized, but it was that those individual attacks, especially on people like Maria, people like Dr. Tedros, it was really hard to watch. It's interesting, when you're being attacked yourself, you have some sense that you have agency in that. It's when you see others around you being attacked that you really feel the resentment. Your blood boils. And it's really hard to stay calm at that moment because the world's watching. So it's very hard. So that's the hardest part, was the personalization, the messages, the tweets, the destructive, corrosive communications. You couldn't open your mouth and there was an instant attack all the time. And that sort of communicate, and it's not communications, it's shouting without context. So I think we have to look at that globally. We've created lots of shouting platforms. We haven't actually created communication platforms. We've created pulpits and soapboxes, yes. So I can have an electronic pulpit and I can get up there and I can shout at everyone. But really, it's not a very safe place for the ordinary person to engage. We have not created engagement platforms. It's unsafe. And people feel unsafe. I feel unsafe. I'm rather large Irishman who's worked in every conflict zone around the world. I've spent my life with my life at risk. And I felt more at risk in the communications job at WHO working with you, Gabby, than I ever felt in Afghanistan or Sierra Leone or in Kosovo or in all the wars I've been in. And that's a personal response. You just do not feel safe. Then how does a teenager feel safe? How does an ordinary health worker feel safe? I'm surrounded by layers of protection, people like you and professionals who guide me through that process. And yet I felt nervous and unsafe a lot of the time, especially in that more open, unmanaged environment. So adapting to that has been really tough. I can't imagine how the ordinary person or the ordinary health worker in that situation has managed to steer their way through this.
I remember you stopped tweeting early in 2020. You just left Twitter. And I think I recall you saying that your family back in Ireland were seeing the ad hominem, nasty, violent kind of comments, and they were getting upset. And you thought, I've got to get off of this, almost to protect them so they don't have to see this.
Well, and the issue is in the value of communication. I've gone to every press conference, jumped on every grenade, done the social media. But you mentioned doing interviews. I don't do a lot of interviews anymore. I've made myself available for the press conferences, but I find that it's been tough, and that's the same for everyone. And I think there was a lot of direct abuse, a lot of threats, a lot of stuff that was very nasty. And I didn't feel at that time that the message was getting through. Every time a message went on Twitter, there was 1,000 responses that were almost entirely all abusive. There was no dialogue. It was just a pulpit for people to attack. And I just felt I'm better putting my energies into the press conferences, into the social media lives where we have some way of safely engaging with the world. And I think that's something that's happened over time. And the other thing I've found and I think I'd be interested in journalists' opinions here, but I fundamentally believe in journalism as, the fourth pillar of democracy. It's interesting in my life abroad, waiting in the field in the 1980s and 90s for the airmail version of the Guardian Weekly to arrive on the post, reading it from front to back and then back to front. And, you're really desperate when you're reading the arts and culture section of the Guardian Weekly at a coffee shop in northern Kenya, or tuning into National Public Radio from the US or to the BBC World Service. That idea that there's another voice and this voice represents a truth that people need to hear. I don't know. I'd be interested. I don't want to appear negative, but I sense that mainstream space has become somewhat debased by the constant hunt for the headline. And it's interesting to me in our negotiations back and forth with media companies over the last couple of years, how much companies have been prepared to change the content of a story, but very rarely will change the headline. And you ask yourself why? Because that's the click, that's the link. And it just seems very strange to me. People are saying, yeah, we'll change that. And you say, well, can you change the headline? No. So you wonder really and it must be difficult for journalists themselves with editors and sub-editors and everything else, because everything is about that soundbite. And we've ended up in a world of sound bites, not a conversation, not a dialogue. And I don't know how we fix that, but it's not been easy from that point of view.
Yeah. On the other hand, I was thinking as you were speaking about the sort of digital social platforms and the downsides. We at WHO have made amazing friends on social media. In the depths of some of the worst attacks in 2020, when President Trump came after us and so on and so forth, we had outreach from just wonderful people around the world. I feel like I made hundreds of friends, and I hope to meet them someday. And to the point where some of them have made videos for us. They've helped us communicate better because people can do it yourself at home, and they've given us advice for how to talk about different things. So it's such a wonderful connective mechanism, everything digital. So it's like everything. And the same thing with media. We've had wonderful relationships with journalists who have thoughtfully reported things with precision and delicacy, and not always positive about WHO, but doing so, like I said, with precision. And yet, as a former journalist, and I was one until about 7 years ago, all my career, I was so upset actually when and we'll talk about this during the panel in a minute, when during a dire pandemic, the worst pandemic in 100 years, the reporting sometimes went into he said, she said, who's up, who's down, horse race journalism, false equivalences, and so on and so forth. But we'll talk about that in a minute. So I think it's everything. It's what it was, the best of times, worst of times, to quote a minor novelist.
Yes.
Okay. Yeah.
Yes,
We're
indeed.
going to wrap.
Yeah.
So thank you, Mike, for this. I think this was good scene setting conversation. And without further ado, panel, come on up. I'm moving down here to my place.
We all move one. I'm okay
No,
here.
you're staying.
Okay.
You're staying. I'm moving. Thanks. And we have two wonderful colleagues who are helping us today. One is Teresa, the other is David at the Zoom, and then Kate Thompson, who is my WHO colleague. And then in the room, I just want to acknowledge many, many WHO colleagues, many of whom do communications and also digital partnerships. And I'm also on Zoom watching, and they make it happen every day. So thank you. So I'm going to kick off, and actually I'm going to turn to you, Hema. Hema, as I mentioned, Hema is the health boss at Google. And as such, can you tell us what you strive and strived to do to ensure that Google's vast, I don't know what you say, client base, followers, users, people, that they got high quality, accurate information in an environment, a global environment where there's lots of not high quality information. Thank you.
Thank you, Gabby. Hi, everyone. It's a privilege and an honor to be here. Thank you to WHO for hosting the summit and having us be a part of this journey. Some part of my remarks is on behalf of Google, but we are also part of the people who go through health journeys, right, on a daily basis. Like I was talking to Rupa earlier, who's got a little baby at home, and you're like, okay, what might be the journey of someone who has a little baby? People start on the internet these days, 3 out of 4 people in the US, 1 out of 2 people in Europe, for anything, starting from the common cold, or why does my ankle hurt, or why is my kid not sleeping? So in the world where people have access to information, what's the role of Google? For us, our role is to bring the most credible, reliable information in a timely manner. And something that you said, Gabby, that deeply resonates with me too. How do we communicate to everyone? I've had the privilege of being here at Google for 3 years, and having worked on the COVID response, I would probably say, for those of you who know the mission statement of Google, or maybe not, it's like to organize the world's information and to make it universally accessible and useful for everyone. If that is true, then it is also true that we apply this to health, isn't it? Then when we think about health, and Gabby, to your question, right, I would actually put this in a few ways. Bring the most timely information. Here are examples. We have information panels on hundreds of health conditions in many countries and many languages. We would like to bring this to every part of the world. And in fact, there are colleagues here from WHO that we would love to partner with, because I think there's a way that we can bring information that's powerful to everyone in the world. There's a second way that you can think about it. We started this morning on our WHO colleagues here talking about the sexual assault. We're deeply sorry for the person, and thank you for the actions that you're taking. But when people go through tough journeys like this, self-harm, sexual assault, domestic violence, Google has a role to play in bringing the best information to find the right help in terms of crisis lines or coping mechanisms. We touched about COVID. Mike, it's a pleasure sitting next to you and sharing this space. I'm like, hey, I would like to know what headline might be written here. But COVID, COVID is an exemplary event that really brought technology as a forefront and as a partner to health and science. We have had the privilege of working with local, national, and intergovernmental agencies, including WHO, in bringing reliable, authentic, credible information to hundreds of countries in dozens of languages. Billions of people access information on COVID on Google. So back to the question that you asked, Gabby. What do I believe is the role of Google? We in Google believe that health is an ecosystem. Health is a partnership. We, as technology, are enablers of science, of working with the right partners in bringing the best information possible. We think of this in three ways. One is consumers. Who are the people that we are serving and what's the best information we can bring? Two is the caregiver community. How do we bring the best tools to the caregivers? And three, and probably equally important, is community. How do we bring the best information to the community so that we make the right policies and the right information available? Back to you, Gabby.
Thanks, Emma. Is my microphone on? Oh, now it is. I'm going to go to KX so we get the meta viewpoint, but I'm going to ask you a slightly different question, KX, which is not only or not really what you did during COVID, but I'd be interested in knowing what your vision and ambition is for Meta's role in global health and helping people with their health and get accurate information going forward beyond COVID. Because as we're seeing right now in the world, I mean, we were all consumed with COVID for a couple of years, but right now we have Ebola. We also have a massive backsliding in routine immunization, meaning people are not vaccinating their children against an array of diseases. And there's so much else happening. So it'd be interesting for you to reflect on where you see Meta going in the health sphere. Thanks.
Absolutely. And thank you for having me. So at Meta, we're fundamentally focused on enabling connection. So helping people connect to the topics they care about most and the other people they care about most. And that really grounds a lot of our work. And as you all know, health is a topic that is really important to a lot of people. I've been at Meta a little over 16 years. And before my current role, I led Facebook groups, among other things. And consistently, some of the most powerful things we were hearing from the people using our products and using Facebook groups specifically was actually the support that they were getting through groups. So new parents going through their health journeys, getting advice from other parents, myself included and my wife included, or, like patient advocacy groups and people getting support around a variety of conditions around health. And so it's something that we've just been seeing. It's really important to people. And we feel like we have a responsibility and an opportunity to better support that on our platforms going forward. And that's really the focus of our group overall. In the context of health, and enabling connection can be very helpful in improving access to information, to support, and in some cases, to services and care directly. And so that's really where we're focused in terms of our work. None of this can be done without partnership from a lot of the people in this room to health organizations and health experts, because our role is not to actually create the information or the services or the support. It's really to enable the people who do to do their jobs more effectively. And that's kind of the high level approach. As you mentioned, we've learned a lot from COVID, and it's been really inspiring seeing a lot of the innovation that partners have been doing on our platforms in the context of COVID. But the core construct of helping improve access to information, to support and care isn't actually specific to COVID alone. And so I think what we're hoping to build on is building on a lot of the successes from COVID, a lot of the things that have been accelerated through COVID, and applying them to other domains going forward. And I can talk about a few examples. So, in the context of COVID and improving information, WHO, ministries of health, and local organizations have reached billions of people through ads, through newsfeed, through products like the COVID Information Center on Facebook and Instagram. Similarly, on WhatsApp, we've been seeing a lot of organizations like ministries of health offer services directly through WhatsApp. So, for example, the Ministry of Health in Indonesia offered the ability to book vaccinations directly over WhatsApp. And in the first 5 days of that service being live, a third of all healthcare workers access that service over WhatsApp. And so I think there's examples like that you could clearly build on outside of the context of COVID. And that's something we're very committed to do.
Great, thanks, KX. And I have a follow-up, which is just, do you want to comment a bit on other topics that you guys are looking to in the post-COVID era? Not that COVID is over yet, but as the Director General has said, the end is in sight. We can get it done if we work hard, but yeah.
Yeah, and a lot of this is actually working closely with the partners because we don't set the global health priorities; the partners do, right? And the way it works is figuring out where are there unique and significant opportunities to use the unique attributes of our platforms, connection at scale, reach, personalization, and in a lot of cases, cost effectiveness, and apply those into public health problems where those attributes actually matter and are significant. So a few of the topics that we've seen success from partners on include maternal health. So in South Africa, there's a program called Mom Connect, which is basically a stage-based messaging program to improve access to information and services for expectant mothers. And it started on SMS, but now is available over WhatsApp. And at this point, 60 to 70% of all mothers in the country are enrolled. And this is a partnership between the Ministry of Health in South Africa, PreCelt, and so on. I think it's a good example of how technologies at scale can improve access to information. Similarly, we have partners who have been working on routine childhood immunization programs across ads and across other forms of outreach. And they're investing, and I think we're seeing some promising results where some of these campaigns have been shown via RCTs to both change and improve attitudes toward immunization, as well as in some cases increase immunizations overall.
Thank you. Now to Rupa. Rupa, I wondered if you would reflect on a few interconnected issues. We've just heard from Hema and KX. And about really their work in the digital sphere. A couple things I was wondering if you would reflect on. First of all, sometimes one thinks of the digital channels and platforms as being inclusive, bringing people together, but sometimes there are divisions created on these platforms where people use them to actually divide, not unite. And then the other one I thought I would love you to comment on is so many people around the world are not connected. They don't have access to digital platforms. They don't even have electricity sometimes. And so how in the global health sector do we reach people, interact with people, learn from people, have that back and forth when either the platforms don't always allow for that because of the divisiveness that bad guys are fostering, or because so many people are not connected?
Thank you, Gabby. I'm going to answer your question, but I also want to acknowledge how you opened the session and say that anytime any sexual harassment, violence, bullying, assault takes place, we must have what we call zero tolerance, but that means everything needs to be investigated. So I want to appreciate the acknowledgement of investigations and encourage that takes place. And we're very much at Women in Global Health, calling for more transparency, much more gathering. We know that health workers face a high level of sexual harassment and violence. The surveys that we have been able to gather have showed at least 2/3 of women health workers report some form of sexual harassment, bullying. It's happening, it's underreported, and we must do something about it. And that is also part of the complexities that we're going to be talking about today. And Gabby, I'd like to speak from 2 points of view. So I'm the executive director of Women in Global Health. We're a global movement with 41 chapters all around the world. We tripled during the pandemic. We were founded on social media using the Twitter platform is how I co-founded and found 3 other early career women without any financial resources until 2020. We grew as a movement using social media communications platforms such as WhatsApp. So the digital space has been part of our success story. But at the same time, I also want to speak from as a physician. I've heard many of my colleagues here bring up, vaccination issues. In the pandemic, misinformation is not a victimless crime. I have seen firsthand practicing in the United States, a high-income country where vaccines were available, but patients were refusing because of misinformation. So this is something that has killed millions, and there's a responsibility that all communication platforms have. And Gabby, you were also asked me a bit about, the different aspects of communication. So yes, at Women in Global Health, we have used social media platforms to advance our agenda, advocate for collective action together. But we also acknowledge that many of the women in our community do not have access to these digital tools. I'll highlight an example of a woman we celebrated last night at the Herons of Health Gala that we hosted. And we have brought 17 different awards were given. Margaret Odera, a community health worker in Kenya, is an example of why communication, not just in digital ways. She's a woman who is living with HIV and AIDS and has respect in her community, uses her personal voice to go ahead and convince other women who may not have tested for their HIV status to take the stigma out of that and say that get tested so that if you are a pregnant woman that you no longer will transmit HIV to your infant. And she's saved hundreds, if not thousands of lives using her personal voice. And it was not through the traditional digital platform, but really recognizing that there are many communities, there's a massive digital divide, and that communication comes in that form too. Another example I'd like to give is we did a study looking at innovation with Fine Diagnostics about testing. And what we found is to reach women in their communities, it must not only be, Twitter is not available in most parts of the world still. And we have to recognize that. And it's no criticism on the platform, but if we want to get the health messages, we still have to look at communication platforms such as radio, community storytelling, and all those things are quite critical. And so, these are some of the things that we're seeing in our space.
Thanks, Rupa. And we'll come back to some of that momentarily. Sophia Smith-Gaylor, you part of your beat, something you cover massively is sexual and reproductive health. And you do it through multimedia formats, including TikTok. And you write about, see, that's me being old fashioned. You don't write about, you cover, you broadcast and amplify about taboo subjects, subjects that are essential, that are health, but are often not acknowledged as health. Or I was wondering if you would speak to that. Thank you.
I do publish on dead trees sometimes as well. I'm not only a TikTok creator, so I have about 425,000 followers currently on the platform. I've had over 130 million views, the majority of them on my personal platform, but also on Vice World News, where I make TikToks for them as well as part of my day job. And my day job is as a reporter, where I file for online. So I do write. I also go on vertical first deployments, where I shoot and edit vertical video for our TikTok and Instagram accounts. And yeah, a major beat for me in that I've written a book about it. It's central to a lot of my reporting. I have a generalist news job, but a lot of the stories that I do are linked to sexual and reproductive health rights and justice. And for me, there is an obvious and urgent need to write about these areas. In my book and in a lot of my work, I label it the sex misinformation crisis in a world where numerous countries do not prioritize sex education, and I would include my own, United Kingdom in that. There is a vacuum of information. When I talk about sex education, I speak about that in a very broad sense. I'm not only talking about national curricula that we have access to as young people in educational settings, but what about the information that we have access to throughout our entire lives? What about training given to the people in power? Notably, in a number of my stories, whether it's been in my book or even in one story I did earlier this year, where I found a content creator who was using YouTube and TikTok to be describe himself in Arabic. He's Algerian based, and he describes himself as a wasit tabbi. And I'd never seen this phrase before. Tabbi in Arabic is medical. Wasit is like a kind of intermediary. And I thought, a medical intermediary? I was like, I don't think that's a job in British hospital, but maybe it's something in Algeria. Essentially, it's a job he's made up, and he uses these platforms to find clients for hymen repair operations for doctors who pay him for the service. He uses these platforms to spread a great deal of misinformation around this element of the female anatomy in order, I guess, to mobilize a client base. This is someone who works with doctors every day. When I interviewed an Algerian doctor who's young, a woman, and really trying to make inroads in combating this kind of misinformation in the country, she herself told me that twice during her medical training in Algeria, she had professors reiterate erroneous, baseless information regarding the hymen and erroneous links to virginity that we know are extensive and widespread throughout the world, including the UK, because it was something I was fed when I was a teenager as well. So in my work, what has become immediately prominent is not only is sex education not prioritized, but platforms in many cases are not best suited to combating this. As a health misinformation problem, if we think about all of the efforts of newsrooms and platforms pivoting to tackling the COVID-19 misinformation crisis, all the efforts to pivot to combating political election misinformation crisis, sex misinformation is so axiomatic and ubiquitous that we almost don't even notice it's there anymore. But it's profoundly affecting our access to healthcare and well-being every day. When I raised that one story, which was a bunch of videos on TikTok and YouTube, normally when I raise dodgy videos with platforms, the videos get taken down within 24 hours before I'm even given a right of reply, and rarely without answering all of my questions. With those videos in particular, for both platforms, it took over a week to even get a response, and for the videos to be taken down straight away, the YouTuber in question pivoted to another account where he was able to buy followers and already assembled a base, making him look like a trustworthy person in the medical field in Algeria. So as much as I try really hard with my reporting to expose things like this, platforms could be doing a lot more to help me get this information out too. But it is a priority for me every day when I can to go on TikTok and not simply rely on the outlet I file for to share my stories. I have to go where the audiences are. And for younger audiences, TikTok, Instagram, this short form vertical video revolution that's happening right now, we have to be there populating it with evidence-based information.
Thanks. And I would add that this moment in time, this moment in history, women's health, women's sexual and reproductive health is in jeopardy, and not just in low and middle income countries, but in high income countries. And I think about the US Supreme Court decision on Roe versus Wade, which is imperiling people's access to safe abortion in that country. We can return to that later, because safe abortion is health.
And Gabby, I have to say one thing though, as picking up on your point, Sophia, we can't be gender blind in our platforms.
Yeah.
And operating in a gender blind way is harmful. And what you're highlighting there, I want to look at you, but the microphone's here. What I want to highlight there is that even when experts, scientists are trying to put the correct information on these platforms, because of the terminology already being so politicized, using the word vagina, penis, which is medical terminology that we use as a physician. It's not a taboo to use. I am trained to use it. If we use these words on our platforms and actually describe the medical evidence, those images get removed, the content gets removed. And it is, again, for politicized reasons, it's getting removed and not for the scientific aspect. So even trying to counter that, I'd have to say we face a lot of challenges. And
I've had the odd TikTok taken down. We know in Facebook ads in particular, when it comes to women's health products and men's healthcare products, for example, vibrators that collect biodata on your orgasms may struggle to secure a Facebook ad, but erectile dysfunction pills, no problem. Yeah. Why is there that disparity? There's a really good report from the Center for Intimacy Justice about that, if you want more information on that area in particular.
Yeah. And as a new mom, I have to say, yes, many of my women physician colleagues have talked about trying to share information about breastfeeding, which is recommended by the American Pediatric Academy for 2 years. If you talk about breasts on digital media platforms, that content's removed. So these are real issues. So let's not be gender blind. And I'm really turning to our colleagues here from Meta and Google. How can we ensure that this is not gender blind work that's taking place, that you're going to be more engaged in health with?
Great. I will give them a chance to comment. By the way, I think, Rupa, I think that your microphone can pivot. Yeah, good. Just so you know. But actually, apropos of what you're talking about, Kai, you have written extensively on the monkeypox outbreak, which is a public health emergency of international concern. And that also presented interesting opportunities and challenges for all of us around talking about some of these issues that are sensitive, but also require candor and scientific terminology and precision. I wondered if you wanted to talk about that and how your coverage of the monkeypox outbreak was informed by what you learned and how you evolved as a journalist during COVID, because you were also a foremost reporter on COVID for Science. And by the way, a great user of social media in German and in English, and you did podcasts. So you are also a multimedia journalist.
Yeah, you could also say I'm addicted to Twitter, sadly. Yes, so it's an interesting question. I mean, I'm always struck when I hear about the experiences in terms of sexual reproductive health, and what we see in the monkeypox outbreak was kind of in a slightly different scenario. It was something similar. So for me, I mean, I'm a gay man, so I'm part of the community that was most affected by this outbreak. And it was really interesting to me how suddenly the conversations I was having also with public health experts, how much the divide between what they were telling me privately and what they were willing to say publicly, how big that divide got. And I've grown very disillusioned, I have to say, through this experience, because what I realized was so the basic situation of what happened was, okay, we see this virus take off. I mean, it's not unexpected that this virus would take off at some point, right? I mean, we've had people like Anne Remoyne and others for many, many years saying, first of all, this is already a problem in countries in Central and West Africa. And we've known that globally the vaccination status has gone down. And so over time, you would expect that this could lead to outbreaks elsewhere as well. So none of this was completely unexpected. But then, of course, it was hitting this community of men who have sex with men. And that was kind of a question, okay, is this just because it happened to get into that group first and it was going to spread more widely? Or was there something here was there a reason why this virus was spreading there? And the data became pretty clear quite early that what we were seeing was an effect of the very dense sexual networks that we see in a core group of MSM versus the density of sexual networks in the general population. So that became clear quite early to a lot of public health experts, but they weren't really communicating it. And the reason they weren't communicating it, or what they were telling me, the reason that they weren't communicating is that they were afraid of stigmatizing a population that already had a history of stigmatization. And I get that, obviously, as a gay man, as somebody who's been talking to people in countries where gay sex is criminalized. I understand that, but there is also a price to be paid for not informing people about a risk that is relevant to them, right? Especially when it's around things that they might not have access to good information about on other platforms or through other paths. And my personal take is that a lot of people, while they were saying they were worried about stigmatizing this population, what was really happening was that they were worried of being accused of stigmatizing the population. And I think that's a big difference, because the question is for whose benefit are you working? What are you doing? And I think that that's something that, that was exacerbated by the COVID crisis. I was talking to Christian Drosten for the podcast a while back, and he said, and I was like, why do you think these people aren't communicating this? And he said, look, so many people in public health are so traumatized from the kind of fighting that's been going on platform. I mean, what Mike was describing earlier, partly on some of these platforms, that when they first started very cautiously communicating about MSM maybe being at higher risk, and they got some pushback online from people who didn't know, who weren't educated on what exactly the data was at that time, they immediately kind of threw up their hands and were like, well, okay, if you don't, I'm not going to be a person accused of being homophobic or whatever. And that's at least here in Germany, that was my experience. It's my experience talking to people elsewhere. And it's also an interesting example of why representation matters, because what you see in the US with Dimitris Askalakis, a proud out gay man who has an identity in that community. What you see at UK HSA with Matteo, who also has that identity, these things matter because these people can communicate in a way that reaches people. They have a certain clout in the population. And a lot of what Mike talks about when he talks about communities in other places, when we talk about Ebola in Uganda now, or when we talked about it in Liberia and other places, you talk about community leaders and all these things. All of this applies in a country like Germany, in a community like the gay community. It's not, these things aren't fundamentally different. They just happen to come in different shapes and sizes, the people that you're trying to reach. But at the end of the day, it's the same kind of lessons. And that's, this whole communication, the fact that we're talking about communication, the thing that most depresses me is that I've been covering infectious diseases for 12 years. And I feel like every time, whether it's H1N1 or whether it's, Ebola in Liberia, every time we have the lessons learned conferences, and of course, they're not really lessons learned, the lessons we should have learned conferences. And then we talk about communication as one of these things. And maybe it's, at the end of this long report, take the Stocking report, take all of these reports. It says at the end, oh, and we need to work on our communications. Communications is really crucial, and it wasn't, taken seriously enough, whatever. And COVID was probably the biggest disaster in terms of communication. So we're not getting better. It is getting more complicated. I get that. I think there is a problem in the fact that Meta, Twitter, Google, these are the people who built the system to some extent, who are beneficiaries of the system more than anyone else. But at the same time, we're kind of having to partner up and ask, to do. I use Twitter for reaching out and reaching people. It's an amazing tool. I can reach a lot of people that way. But there's a fundamental, it just strikes me that there's something fundamentally deeply ironic about the fact that this is what we're kind of forced to do. And I think we need to have it's a bit pointless, but we need to have a reckoning about how to do these communications and how to do that better. I want to make one final point. Sorry, I'm talking way too long, but the point that always strikes me is that as long as we talk about communications just as kind of this closed field of communications, we're not going to get anywhere, because what's at the heart of this, of course, is it's the polarization, it's the populism, it's that what's been called the post-truth moment. It's the fact that we need trust. And yesterday, Ilona Kickbusch, I think in one of the sessions, was talking about the fact that the countries that came through this pandemic best were partly countries where there was a lot of trust in public health agencies, in the government. I interviewed Bill Gates recently, who wrote the same in his book. And I said, okay, then why don't we work on that? And he was like, well, we don't really know what to do on that. And so we keep just going back to the things that we do know how to do, which is like, okay, how do we produce a vaccine faster? But at the end of the day, we need to tackle these hard problems of how do we build the kind of trust that allows us to have any meaningful communication in the first place. Because even with my 150,000 followers on Twitter, I'm mostly communicating people who basically more or less agree with my, balanced views on these things. That's not communication, not really. Like Mike said, it's a soapbox, and the people who stand around your soapbox are the people who, who stood there last weekend as well and really like what you say. It's not, that's not how we get anywhere.
Yeah, it's a bubble. By the way, the countries that acted swiftly and wisely early in COVID, I think they were not just the ones that had their communities' trust, but in communicating quickly and immediately on January 30th, when the public health emergency of international concern for COVID was declared, they earned it by warning their people and deploying rigorous public health measures. The ones I think that failed were the ones that didn't heed that, let things kind of drift for months, and then belatedly decided, oh, we need to protect our people. But anyway, that's just a personal viewpoint. Before we go back down the line, Mike, you're my last panelist who hasn't had a question, and I left you for last because we had our conversation. But I wondered if you could reflect on two things that Kai said, because this has affected us. And when there are pile-ons, when people pile on anything you say, quick trigger reactions. So you say that the monkeypox outbreak in Europe, let's say, it seems to be clustered in MSM communities, and then immediately you have all sorts of, quick trigger reactions. Oh, you're being homophobic. So could you comment on this, the need of public health authorities such as WHO and yourself to be able to communicate frankly, and yet we also sometimes feel we have to tiptoe. So this kind of, you second guess yourself. And then the other one is, I think it's important to talk about communications, to your point, Kai, that we shouldn't talk about communications in a vacuum, that it's integral. The WHO's emergencies program under Mike has multiple kinds of communication work going on, precisely because it needs to be integrated throughout all the work. And there are some interesting things that Mike can speak to that, which is our risk comms, our infodemiology, our community work. So I wonder if you could talk about those two things, and then we'll go to HEMA and KX.
Great. Well, first of all, it's the first time, Kai, we've shared a public platform. I just want to say thanks to him personally, to Helen Branswell, to John Cohen, to Jason Gale, and those other sort of media science journalists out there over the last 2.5, because I've learned as much, because I'm overwhelmed with data and information. I go to your Twitter feeds and your threads, and I get that pocketed information, even on our own press conferences sometimes, actually. So it's been a shining light, and I think science, journalism, and the communication science is alive and well, and people like you are the stewards of it, Kai. So thank you for that. And as Gabby said, it's not about being liked. It's not about WHO is well used to criticism. We should be held to account, and radically held to account, because we're a large organization with a huge influence. But it's just great to be here with you, and I'm very honored to share the floor with you and with everyone else. I think maybe in terms of context, it's quite a different communications challenge at WHO, because we're communicating with 194 member states. We're communicating with people across the most, and it's probably the same for the big platforms to sit here. So the message that we might say in Europe will be completely interpreted the other way. I'll give you an example. When we did the DG decided to declare a public health emergency around the monkeypox outbreak. And there were all kinds of as pros for and pros against. And I remember the immediate aftermath. I have gay friends on both sides of the North-South divide, and my friends in the North were saying, "At last, you guys have got it right. You had the courage of your conviction, and you've done the right thing. This is great. You've now done the right thing." And at the same moment, I was getting a message from two gay friends in a country in Africa who were absolutely terrified that would, and the message to me said, they've never come into our home before, now they will. Because they felt that the declaration of the faith would allow a surveillance state to actually actively come in. And I was in the same moment, and friends from both sides of the North-South divide, but on the same side from a sexuality point of view. And I was really conflicted because of that. So when we talk about the communities, there are differences even within. I mean, there are various tribes in the world right now. People identify in various groups. So I might identify as part of a gay community, but I'm also part of a journalist community, or I'm part of a football followers, and we all live in this sort of digital tribes right now around the world. And it's very difficult then for WHO to get that message right, because what may work well in Hong Kong doesn't work very well in Honolulu. It doesn't work very well somewhere else. So that's always been a challenge for us. So sometimes we look like we're tiptoeing around issues. What we're trying to do is get a balanced message out that will resonate in all places. And then with that, in terms of that infodemic we've all faced, I mean, that word trust you raised, Guy, I think the biggest missing commodity, we talk about access to countermeasures. We talk about drugs, vaccines, therapeutics. We need to add trust, because that's the commodity. Everything in life we talk about, what do we monetize here? Not communications. Communications is a methodology. Trust is the commodity. And that's what we fail to build at all levels. We're in Uganda today, and we're dealing with local communities. The alert system isn't working that well. And you ask why? Well, a lot of marginalized communities, migrants, people who've been refugees out of other countries, people working in illegal gold mines. There's a community, but the community is very diverse, even within a local area. So when you talk about let's communicate with this community, it's multiple communities, even within a small space. And being able to do that authentically is quite a challenge. And when we look at fragile, conflict-affected and vulnerable settings, 1 in 5, 1 in 6 of the people on this planet bear no relationship to this meeting or to anything we do in our normal lives. They are completely bereft. They have no government. They have no human rights. They have no law and order. They have no guaranteed access to food, to safe delivery, to sexual and reproductive. They don't have anything. And I think we need to think about what are the trust and communication solutions in those settings.
And Mike, if I can just chime in, I'm so glad you bring up that point. I mean, we are having this conversation without those communities represented. In the sense, I am a part of, I lead a global movement that does have chapters in 41 countries around the world, majority in LMIC. And when I hear from our chapters from LMIC, they say, first, we need to be creating the solutions, not be the target population, but we need to be in leading roles, co-designing. Mm-hmm. And I think that's what you're touching upon, that, these communities need to be part of the communication that's being created, and they have the trust, and they also know the solutions.
And we other groups, I mean, we talk about traditional healers, and very often in medicine or public, we talk about them as the problem and they're spreading the disease. The greatest education I ever got in Ebola was in 1996 or 97 in Gabon, up the Aguya Vindo River, sitting in a small village with a witch doctor. She was the leading lady witch doctor for a whole area. She had massive, talk about influencers. That's what I learned about influencers, right? She didn't need Meta platform or the Google platform. And what she, and there was a process of cutting, scarification was used as a way of healing, and it was to do with spirits. And it was valid within that community setting. And the invalidation of traditional methods and spiritual methods is so pervasive in medicine because you don't factor in the good that does within the community. We don't understand the support people feel, and that sense of belonging and that sense of spiritual support. You could believe it or not believe it, but it works in the context of those communities. And I remember sitting with a bunch of, at the time, other colleagues waiting to see this lady. And eventually she left us out in the hot sun for about 4 hours. I think she was teaching us a lesson. And eventually we got in to see her, and she was sitting on a big wicker chair, and she was like Queen of Sheba. And she left us for another hour, and then she gave us an audience, right? And then we tried to explain to her, and she stopped us, and she went and gave me the best lecture I've ever had on the bleeding disease. And, you know, and she told me that this disease, yes, this comes in the season of red fruit. We take care of that. We burn the houses down of the people, we bury them safely, and we don't take those sick animals in the forest. And I said, well, that's what's caused the outbreak. She said, yeah, but who took the sick animals? And I said, yeah, it was the forest workers. They don't come from here. They've come from the city. They can't hunt. We can hunt. So we can hunt a healthy animal. They can't trap a healthy animal. So they look for the sick animals. And it was exactly the story of the outbreak. It was people coming into the forest to exploit it for wood, who were using hunting as a way of supplementing their incomes. But because they couldn't take a healthy animal, they were taking the sick animals, and that started the outbreak. And then she said to me, and this disease, the season of the red fruit, it comes after drought. When we have drought in the forest, and I don't think drought in the rainforest, you know, but after that, sometimes it rains heavily, and then we get this disease. And I thought, it's kind of, these are fantasies. About a year later, Pierre Fomonti, our Ebola guy, right, comes into my office. He said, Mike, we've got this great project going at NASA. I said, what is it? He said, oh, we're doing this vegetative index differences, and we're looking at stresses in the rainforest, and we're looking at drought stress in the rainforest. And we found that actually after periods of drought stress, we tend to see these Ebola outbreaks. And I was remembering this lady in the middle of nowhere, right, who through her observation as a person had basically that story. And it taught me a huge lesson in understanding, not just, we often in communications try to find the channel so we can convince people. So it's about us opening the channel and creating the platform. It's not communication. It's a two-way process. Yeah. And that listening part, and I've learned that lesson. And just to get everyone on that, one of the things we've done with infodemic management, which I think has been innovative, we've opened up this world of work, world of faith, and we've engaged with all of these organizations, unions, employers, faith leaders. I never thought in WHO, given the trouble we had with HIV and condoms, that I'd be online with imams and bishops and archbishops and all of these different groups. But that engagement, in engaging in the groups that people engage with themselves through their normal lives, not trying to go direct, but use the channels that people use for other important things in their lives, we found that one of the most effective ways to communicate during this pandemic.
Add one thing, because I think what strikes me about that story is that one of the things when I teach journalists, what I say often is that we really need to expand our definition of what an expert is. Like, yes, people have very, very narrow definitions. Like, to be an expert, you don't have to have got, like, literally for the monkeypox outbreak, like some of the most valuable information I got, of course, was from people who were really clued into the gay scene, who could tell me, you know, okay, what was going on in Berlin at the time? Like, were people changing their behavior? There are people who've lived their whole life building up an expertise that nobody who goes to university is ever going to be able to challenge. So that's something really important for journalists, I think, as well, to really look broadly as what we think of as experts.
Yeah, it's about intellectual diversity, right? I mean, fundamentally, it's about being open to multiplicity of ideas, not just ideas in one or two bubbles.
If I can,
PhD bubble, yeah.
Just one last thing, because that brings us back to trust. Naomi Oreskes wrote that book, Why Trust Science? And her whole argument is that there is no one scientific method that you can trust, but what we do have is a consensus finding mechanism that is better the more diverse the group is that comes up with that consensus. And so if we do want to build trust, the idea of including many, many people in this endeavor, this scientific endeavor of trying to build a consensus, that is the best method that we have for that. And we need to work on that, but we also then need to, I mean, all the polarization and the fragmentation that we see, of course, goes against that. It makes it harder and harder to do that.
Especially, that's a good bridge. I'm gonna, we have only a couple of minutes before we go to Q&A. So I actually would like Hema and KX to reflect on this, because you work for massive, massive platforms, obviously. And if you could kind of summarize your reflections on this conversation, both as professionals, but as human beings, and the responsibility you have, the constructive things that your platforms bring to the world, but also the risks and problematic aspects. Hema.
Thanks, Gabby. We all come to these forums with, here are my talking points, stick to them, say them, get off. I actually did want to reflect back to you, Kai, Sophia, and Rupa, that your message is heard. Thank you for sharing. I think I believe that information is a determinant of health. Yeah. It does help to look at the person when you're actually talking to them, but yes, I will look at the mic. Thank you. Is it better? Yeah. Okay. So fundamentally, I believe that information is a determinant of health. This conversation reflects on a separate aspect. Information and trust are determinants of health. Then in that journey, what is the role of platforms like Google or YouTube to build that information equity, to bring as much communication as possible in a credible manner, work with the ecosystem? The ecosystem, as Gabby pointed out, the intellectual diversity. How do we build a partnership with researchers, policymakers, journalists, the health experts, as well as maybe technology experts? Where might we go if we have to believe that there are billions of people that we can reach? Health is only one of the areas that we started talking about today. How about climate change? How about food security? How about gender equity? How about digital access? We got a long way to go. But I'm an eternal optimist. I fundamentally believe that the role of platforms like Google and YouTube can be to provide reliable, accessible, credible, timely information. We can make this really relatable in some ways. We are looking for partnership. We are looking for partnership both on this forum, out on this podium, as well as in the audience. Reach out to us because we got to build a better world together and better health for all together. Gabby, back to you.
Thanks. Over to you, KX.
Thank you. I think this is obviously a topic we've been thinking about a lot over the years, even before the pandemic. And I think one of the major learnings I've had is that misinformation really thrives in the absence of trusted and credible information. I think that's something a few of you also mentioned. And so I think that the solution needs to really be two-pronged, both reducing misinformation directly or removing misinformation directly on the platforms, but also figuring out how we can work together to increase access to trusted information, increase access to credible information. And as Hema mentioned, I really agree, the platforms also have a unique role to play there. And the things I've seen to be most successful here tend to be where you go to the organizations today, online or offline, that are already really good at building trust, that already have the trusted relationships. And this actually isn't always the traditional definition of expert, as we talked about here. And that requires deep partnership, right? How do we work with these organizations? How do we find these representative organizations and work together to build the capacity together toward this common goal of improving access to information, support, and care? And I agree with him. I think there are opportunities here for us to work together and achieve that common goal.
I have a question, though, about that, which is, you mentioned that the tech companies obviously need to work on eliminating the lies on the platforms, but also need to disseminate trusted information through partnerships, because you aren't content creators per se. You're getting, what I worry about is that the purveyors of lies, the bad guys, have more seductive messages, and by flooding in accurate, authoritative information, can one really drown out the vast, tsunami of these compelling lies. And that's really what scares me. And then the other thing that scares me is, how do we work with people everywhere so that they can think critically about the lies that they get fed, which endanger their lives and their health. So it's about, I feel like these problems are monstrous. One is helping people raise their children to be critical thinkers. And then the other one is this monstrous torrent of lies that really swamp the more nuanced, accurate information. But I have to go to the audience and online and in person, because I promised an interactive conversation, but I wish we could.
Gabby, can I chime in as a physician that has had to convince people?
Yes.
A lot has been said, and reflecting as someone that has spent over 12 years of medical training, I do want to challenge the narrative who are the experts, because not everyone can be an expert. I think it needs to be this part of partnership. We can't be naive about it. Misinformation is killing people. I have had to face patients that are turning to those that have more followers than their physician to say that's the accurate information. Pregnant women saying they're going to refuse the vaccine because of misinformation that's out there. And even today, pregnant women are refusing to get the COVID-19 vaccine. It's killing people. So when we are talking about responsible communication, I think it is very critical to say, what are the sources? So root sources for myself as a physician, I turn to the professional societies. International organizations like the World Health Organization has been an incredible source that I cite. Other national authorities that are still credible and not politicized are still sources. And it's more about making sure that we have root. I agree that, journalists definitely get expertise and are critical, but we need to know where you're getting your root information from. Otherwise, it's a big issue. I interviewed medical students, and the top issue that they said in the last 2 years for the first time is that their misinformation and patient trust is what they're the most worried about in their medical training. So I just want to put it out there, Gabby. This is in that way. Thank you.
Yeah, no, I'm glad you made that point. So we're going to go to the audience. I see yellow lanyard. Thank you.
Hi, thank you. Is this on? Okay.
Feel free
perfect.
to say your name if you're comfortable doing so, and your organization,
Yes.
or not. Up to you.
Hi, my name is Farangis Gafur. I'm a journalist from the Tagesspiegel, Berlin's biggest newspaper. I have a background in immunology, so I'm always very keen on attending these panels. My question would address the representatives of Meta and Google. As you heard on this panel, we have an urgent need of proper information. We have journalists here that are addressing this, and I would ask for a concrete answer rather than a general answer. I think it's nice that both of you are acknowledging that we do have the need of trustworthy information, but what are you actually doing for that? That goes beyond just a banner on my Insta stories that says, oh, this might be false information. Check about COVID-19 information from the WHO. Because I think me as a journalist, and from all my colleagues, what I can see, we have control over our own platforms. We have control over our own storytelling. And I barely see misinformation from the colleagues, or at least from my peer group, let's put it like this. But the spaces of Meta and Google, I'm not the one who's controlling this. You are the ones who are controlling, like not you personally probably, but your companies. You're the ones who are putting the algorithms. You're the ones who have power here. It's not us, the people. It's not, I wouldn't consider it as a democratic space in this case, as a space where press can do whatever they want to do. And we have, I think media outlets have seen the urgency to also create content in these spaces, because if we don't do it, then we have undemocratic forces filling that void. If we don't do it, we have people that can call themselves journalists, because at least in Germany, everybody can do this.
Thanks for your question. I just want to make sure there's time, so we understand your question. Hema, yeah.
Can you guys hear me? Yeah. Let me give you one very specific example, since you said, hey, no more generalities. I hear the question. When you look at a search result on Google, you can actually look at the source of where this information is coming right now. try it out, buddy. Like, I think it is one, do I agree with the premise that everything that we put up needs to have a credible source, especially as it is addressing a health issue? Yes, I personally believe so. Two, are there tools for you to do that? Yes, please do give it a try, because this is something that we care about deeply as well.
Do you want to mention the work we did with you early on in, I guess it was 2020, my colleagues, where you were working on creating, I don't know what, boxes on
The
on
information
Google
panel.
to highlight so that when people search, they would get results from various CDCs, Ministries of Health, WHO.
Yes.
I don't remember what it's called, but you'll know what it's called.
These are called information panels. Thanks, Gabby. She did answer the other specific one. I wanted to go to the search results question. There are, for a number of health conditions, hundreds of health conditions, you can actually find information panels that talk about, that come from very credible sources. COVID is an example where we rolled out the feature in hundreds of countries. And this was in conjunction with WHO, with CDC, with NHS, with COVID in India, and a few others, because it is both local, national, and intergovernmental agencies that had the right information that we can portray. So I can actually go through a few more examples if you're interested.
I have a solution to pitch as well, building on Farangiz's question, but this is research that YouTube took part in. I believe it was Cambridge, but there was research earlier this year that found that pre-bunk videos, that's what they called them, using pre-bunk videos in ad space on YouTube served to inoculate audiences against misinformation. I would love, you have people here who are storytellers who know how to, I know how to make something viral on TikTok. You know how to make something viral on Twitter. Platforms should be using us to help make these pre-bunk videos and should be sacrificing ad space so we can help get in there. And it's not always relying on our own platforms that we all build in our own time, sacrificing privacy, sacrificing our mental health, online harassment. We go through all of that, as do doctors. I bet that doctors in here who faced online harassment, have you ever been supported by your workplace in how to combat or deal with those moments? Up until the job I have now, in terms of online privacy and safety, I was simply told, don't post. Mm-hmm. We're talking about comms. That's not good enough. We need better protection. And that is a partnership that we could start tomorrow.
Yes,
Pre-bunk,
it's great. Pre-bunking. I think that's, I agree.
And I have to say, all health workers are reporting the mental impact. And we did a launch here in a session about Great Resignation, exactly about that issue. So no, we're not supported enough.
Yeah, getting ahead of the torrent of lies. KX, your comment.
Yeah, I agree. I think the pre-bunking idea is great. I think it's very consistent with partnerships we've had already with a lot of health organizations to make the best use of our ads platform and our organic platforms, right? It's not just ads, it's also making use of Instagram accounts like you do to disseminate information. So that's one concrete part of what we're doing. When that information's out there, it's also important that it gets distribution. And so we've made concrete changes around how we rank to promote this information more. So I think that's another concrete step. But I do want to emphasize, we have a lot of responsibility on our end, and I think it's very fair and helpful to get criticism on how we can do better. But this is fundamentally also a whole of society problem, because we do not create the content ourselves, right? We're not the experts here. And so it requires an ecosystem of people who can do that. And I think we need to work together to do it.
Can I just come in on that? Because I really support the pre-bunking approach, but I also want to go back to something you said, Gabby. It's really important that we don't weaponize communications and create, we become the owners, the people who put out misinformation and disinformation are the bad people. They don't get to use these weapons, but we're the good people. We'll use the weapons. I think the most important thing for me, and you said it, we need to educate our kids to be consumers, skeptical consumers of all information, including the stuff we put out. I want to see healthy skepticism. I want people making informed choices about their health. And informed choices means asking the tough question, asking the easy question. I don't want to propagandize people into health because it's not sustainable. because the challenges next year will be different, and they'll be different the year after. What I would like to see is a generation of people who ask the right questions and then can find the right information. At the moment, we're in a crisis, and I think we have to do the pre-bunking thing. But I think the long-term objective is to create people who engage with information and ask questions about their health. And, you know, sometimes we demonize people, the anti-vaxxers and all of this. There are many people who have valid questions about putting pharmaceutical products in their bodies. And those questions are valid and they need to be engaged with and answered. At the far end of the spectrum, there are people who willfully spread disinformation and misinformation, and they're the minority. Most of us are caught up in the maelstrom. We're caught up in the rolling waves of information. And I just would like to see that much more positive engagement, giving people the skills. We had the same issue in COVID. WHO needs to put out more direct advice to people. You need to tell people what to do, and we need to have this much distance and close it. Should I get on the bus or should I not get on? WHO needs to tell people in Hong Kong whether they should get on the bus or off the bus. I don't know. I don't know about buses in Hong Kong, or I don't know about buses, you know. The real question is, we're trying to get out that across, is we need to teach people to be risk managers. It's the same in COVID. Manage your own risk. Know the risks, know what the risk factors are, and then reduce those risks to the value you can. But if you're a single mom working in a developing country and going to work is the difference between you feeding your kids tonight and not, then it's a greater risk in you staying home than there is the risk of being exposed to COVID. And we do that as human beings. So I think what we also need to do in communications is also teach people to be able to manage the risk in the communication environment, give people tools to do that. And then we need to go to war in a sense against the others who weaponized on the other side. But I think we have a lot to do in the education space to empower people to engage in this new. I feel, my kids are just in this world. And I feel lost. I feel truly lost. And I think I'm, pretty hip and pretty nice. I'm lost in this world, and I don't know how to navigate.
So
I really don't know how to navigate.
So Mike, I want to respond with the solution theme here as we're coming, I know, Gabby, to a close. I want to say, my call to action on this is let's have diverse voices and communities at the heart of communications, and diversity in gender, but broader, geographical, all racial. We can name all the different gender, sexuality that can go on into intersectionality, but we really need diversity and an environment, an ecosystem that's enabling for everyone to really participate in communications.
Can I just ask my colleagues, how many minutes do we have before the Zoom shuts down? 3 minutes. So, and you have to leave, Rupa. So Rupa and I are going to indulge you for 1 minute because Rupa has to catch a plane. We're obviously not going to get to questions, but maybe some of our colleagues on the panel can hang out and chat with you or share a business card for later. But there's a friend and a colleague of ours who couldn't be here today. She would have been here asking the best questions. Her name's Nicole Sheik. And many of you here in the room and online know her and love her. And she's fighting hard for her health. She has stage 4 colon cancer. She's 45. We love her. And we just wanted to pay tribute to her today. Rupa, do you want to, so hi, Nicole, if you're awake, which I hope you're not, because she's in DC. We love you. You want to just say something quickly?
Yeah, Nicole is a global health woman leader. She's a bridge builder. She comes from a communications background. And I have to just say she is fighting this fight, and we're all thinking of you, Nicole. Thank you.
So thank you for that. And we're thinking of everyone around the world who has a loved one who's struggling with a mental or physical challenge, or who is struggling. So if you have loved ones or you are struggling, we send you love and support. With that, I'm going to wind down. I want to thank Kai, Sophia, Rupa, KX, Mike, Emma, and all of you and my colleagues for today. I really wish we could keep talking. I don't know. Thank you. It's been really meaningful. And with that, I'll close and have a good rest of the World Health Summit. If you need to reach me ever, it's sterng@who.int. For whatever you need, reach out. Thank you.
Thank you.
Thank you.